Hi guys. Hey, today we're going to do something a little bit different. Okay, we're going to look at PCRs. We're going to do this by having a scenario that we're going to watch, and then we're going to go through the PCR and we're going to fill it out. Now, when we fill this out, of course, I'm going to be filling it out the way I would fill it out. So there might be some things that you don't do, some things you haven't considered, or some things that you do, so don't worry about it. But we want you guys to come out with a better understanding of how we work, how we see this as a QA/QI reports. When we give you a report back, it says, hey, this is a good report, but did you consider? Maybe we're not seeing the big picture that you saw and seen. So we want you guys to get in the habit to where if we have a report and we give it back to you, you don't think we're criticizing what you do. Also, our goal is to, if you have a PCR written, that if we have to come back to it in a couple of years, or you had to come back to it in a couple of years, you have a full understanding as well as what you reported and what you documented, and that it's a clear documentation. We don't want you to write a report where in one part of the report it's documented you did something, and then the next part of the document it's not there. So sometimes a lot of the tabs, a lot of the drop downs we don't indicate as such that we assessed it, but yet in the narratives we say we assessed a patient. So with that being said, let's go in and we'll watch this call transpire. Some of the numbers, some of the patient-related information is not there. Obviously, this is from a TV show, but we'll make it up and we'll enter the information through the PCR, and I'll give you some of that extra information that we had. So if you want to kind of follow along of how you would do the report, it'd be a good basic starting point. But again, so let's watch the video and then we will go from there.
Rescue 13.
Rescue 13, 57-year-old male. His wife says he has an internal defibrillator for his heart that keeps going off.
Acknowledge, thanks.
That's not the guy.
The same
that's
guy,
the
yeah.
guy with the pacemaker?
Yeah, that went off yesterday. I recognize it from a call we had the day before. He refused all treatment and care. So red flags go up because there's obviously something wrong with this patient's heart, and at any point he could die.
Is that him right there?
Yeah. Good eye. Hey, partner.
Ain't nothing wrong.
But it keeps going off, buddy. I'm afraid you're gonna die. Do you know why it's firing? Because your heart's going too slow or it's going too fast. And it's firing multiple times means something's going on with your heart. Listen, look, I am afraid that we're gonna get a call in about an hour and you're gonna be dead. How many times has your defibrillator gone off?
I just want to go home.
I understand. And I want to make sure that you can get home, but you're gonna die if you don't go to the hospital. Oh. I knew right then that he had just received another shock from his defibrillator.
What's going on, man?
Fine. But you said that last time that we saw you on the last block over there. You said you was okay. I am.
How many times have your defibrillator fired since we seen you last time?
I just want to take me out and lay down. Come on, man. Why are you walking away? I'm fine. I am.
Buddy, it's game over. Send me TPD. I'm gonna need a Baker Act. If we feel that the patient is going to be a harm to themselves or others and are refusing care,
No, just leave me alone. I'm fine.
No, we can't leave you alone.
they can be Baker Acted and forced to go to the hospital. And they don't let them leave the hospital for 72 hours. He's going now.
No, come on, man. I'm fine.
It's game over.
Come on now, so you just gonna run off again?
Fine. Good.
Yeah, you
If
good.
you run,
but
they're
your
gonna
defibrillator
arrest
keeps
you.
firing.
Ryan, come here, baby. Ryan, come here, baby. If you run, you're gonna get arrested, baby. I just want to check you out, sugar.
This patient's getting too worked up, too agitated, and we decide we're not gonna chase after him. We don't want to push this guy's heart to the limit to where he gets shocked again. He jetted out the side and ran away.
Shot him 4 times back to back last week. He wants to go to the hospital, but he's concerned about this little job that he got going on tomorrow. Because my grandbaby birthday, he said he want to get her a lot of gifts.
Now I'm in a dilemma. Do I have this guy Baker Acted for 3 days, not letting him get to his job and get gifts for his granddaughter? I obviously got to err on the side of the patient's health.
Listen, if you go voluntarily, They'll
I
check
can't
you
hear
out.
you.
If you're okay, you come home. If you make
Let's
us
go.
listen,
Open up file. Let's go.
okay, let's
Well, he's pulling the rescue car around right now. We'll hook you up to the monitor out here.
Right here. And you
Okay.
seen nothing wrong.
Okay.
You seen nothing wrong.
Okay.
Nothing wrong with it.
Okay.
Nothing wrong with it.
At this point, I'm pretty sure that it's going to show some type of abnormality so that I can show him that something is actually wrong with him, and he will let me take him to the hospital.
Everything looks fine, and this is just driving me nuts. And it does. It looks fine.
Okay. I mean, y'all are the medical. If he's medically good, there wouldn't be a reason I think.
Even though the EKG showed no abnormalities, this patient still could be having a cardiac event. If he's adamant about not going, I don't wish to Baker Act him, but he's definitely going to need to follow up with his cardiologist.
Okay, Ronnie, listen to me, okay?
So,
No, my turn. I'm gonna have you sign another one of those papers. If I come back, look at me. You're going to the hospital with me, okay? And I don't want any arguments. I also need to say, in front of all these people, that I think it's a horrible choice that you're not going to the hospital and that something bad could happen to you. Do you understand that? Okay. You are signing against medical advice. We are stating that you need to go, and you're stating that you're not going to go. Yes, if you don't mind.
appreciate you doing what you did,
I understand.
but ain't nothing wrong with me.
I understand, but I'm worried about you, and it's my job to be worried about you. I take 10 people to the hospital a day that don't need to go, and you're the one that does.
Okay, let's say that call's finished. We wrote all the information down, took some stuff on scene, went back to the station, filled it out. Obviously, some of the things within our report that we'll see in EHR that I cannot recreate is the 12 lead. But we'll look at this report. We'll go over some things that we're seeing in QA/QI, some things we'd like to see completed. When the report's done, we'll lock it out, and then we'll show you when we create and generate the report that you've written that we look at when we are reviewing your cases, what we see and the information that we're seeing and what we don't see. So some things that we want you to think about in the future going forward, that we fill this out so we get more of a complete picture. We understand that when we look at these reports that we're looking at it from an armchair quarterback type, right? We weren't there. We don't see what you saw. So a lot of times when we do write comments on these reports and we look at, we send them back out for you guys to review, we do get those big comments back. Well, the patient was this or this, and the patient was doing this, and that's totally fine. Just we want you to document it. So when we look at that, we can say, hey, look, they're on scene for 12 minutes, but they only got one set of vitals. We also got a refusal. Per our policy, we need to get 2 sets of vitals. And if we only got one, why? Let's see why. If you guys stayed in there, the patient was not being cooperative or was walking around the house, loading their things up, packing their things, or on the phone to see if they needed to go, and then the ambulance got there, that's fine. Just state in the document, in the narrative somewhere, that patient was moving around, patient, for whatever reason, we didn't get it. At least that way we know, and it builds a better picture. In 2 years from now, 3 years from now, if something ever happens with this case, we go to court, then you're going to have to verify that your record's complete. And if you don't know why there's such a discrepancy in the time frame from when you saw the patient, from when you did vitals to when you didn't do something, or you did do something, that there's a reason for it. You don't have to recall on nothing. You don't have to sit there and go, well, I really don't remember. Document as thoroughly as we can. All right. So let's get into the report and let's look at the EHR on this call. We'll pull it up here. I've already completed the call for the most part. There's a couple things I haven't completed. We'll see that when we go up to the checkbox here in a second to see if we're good. Really quick coming down here. This stuff is pretty verbatim. We get this stuff all the time. We see that we filled out all the demographics the best as possible. Change all the time, change the city to the Woodlands. That way we look at these metrics, we can pull it up from the Woodlands calls within our district. Really easy. Again, information if we can get it. If we don't get it, that's fine. History. I get a lot of people that sit there and go, well, what else? If there's other issues that they have and it's not listed, what can we do? Again, just cardiac condition other. If we need to make comments on it, make comments on it. Okay. Go through any known allergies, medications. Again, sometimes we get patients that throw in a lot. I personally will write down what I can. If I can't write it all down, maybe they say, here's my bag and there's a bag of it. I'll just write add medications, I'll do other, and then I'll go ahead and make an indication that several medications regarding patient's history. So it is important to get a history. I try and fill it out. Also, we've had cases in the past of belongings. Hey, did you see the medics this or the patients this? Yeah, well, we gave it to the medics. Oh, well, the medics say they don't have it. If we touch anything of the patient's, I will add the belongings to this. I will go add belongings. What did we have? Other, whatever. And then I'll make a note, especially cell phone and chargers for the cell phone. We'll do that, and I'll come in here in details. I'll put given to the medic, any comments, cell phone plus charger, given to medic unit, whatever unit it was, or if you know the medic's name, give it to it. I document it. That's just me. That's a court case. It's not a big deal, but that's something down the road. If you want to do it, you can. Vital signs, again, the vitals. What did we do? Again, were they alert? What side did we get the vitals on? How was the patient? So in this case, off that scenario, again, the patient was standing, leaning up against the car. They're standing. Got all the information the best we can. What were their stats on the room air? How did we get the blood pressure? Where did we do it? Was it a manual? Was it an automatic? In this case, we said the first one was an automatic cuff. The second one was a manual. We come in here, hey, that's not right. So let's go and we'll change it. We can go and change cuff automated. Okay, cool. We're good. Flow charts. Again, we did assessments on the patient. Let's document when we did these. Flow charts are really important. Helps again with the flow of the incident, how the flow went, how the call went. Right. On here, document what we did, what time we did, what was the response to treatments. So they're calling them treatments. That's just how it is. Let's just do it. Again, this patient was real basic. This was a refusal. We're going to go into what we do if it's a difficult refusal. Dr. Patrick wants us to address a couple things with you guys, and we'll get there. Again, assessments. Now, with this incident that we had you guys run through and look at it, just kind of think about how you would go ahead and document this patient. We didn't do a whole lot of touching on this patient, but we saw him ambulate, we saw him walk around, we saw him move his arms, took his shirt off so we could do EKG. So with this stuff, we may not have done a true hands-on physical assessment, but visually, how did the patient look? Did they look like they have anything? Did we notice anything? I think on here on examples, nor abnormalities, I did put accessory muscle use pain, no pain with inspiration tenderness or general. Then I made a comment. During leads placement, limited physical assessment revealed no sign of recent trauma or injury. Scar from past cardiac procedure was present. Patient did not have any pain to chest. Again, this is just what I do. Yes, I did not touch the patient. And there's going to be some of y'all that say, well, if I'm not touching the patient, I'm not putting that I assessed him. I understand that thinking, but when we walk in, there's several times we walk into calls and we see a patient and we go, man, that patient just looked really bad. Why did he look bad? Just think about it in this aspect. If you're trying to talk to somebody about the call that you had and we walked in and said, man, that patient looked like crap. Well, generally the next question from somebody who's listening goes, well, what'd they look like? Oh man, they were gray. They had no color. They were gray in color. They were sweaty or diaphoretic. They just look sick. We assessed them, right? We didn't physically touch them, but we did visually assess them. I do get some questions about, well, extremities and the arms and the legs. Why? I didn't see it. I didn't look at anything. They had pants on. But did they ambulate? If they walked around, right, you didn't notice any abnormalities. If you did, again, document it. If you notice something, there's many times we make patients with difficulty breathing, but we walk in and they've got weeping leg wounds that are, grotesque bandages and it just smells or whatever. We notice it. I will document it that I noticed that. The other thing, like, for example, the extremities in this case, visual assessment with no sign of injury to patient and no complaints of pain from the patient, right? So in my narrative, I'll talk about, I may document how they ambulated. So those are just some things to think about with this patient, this case. So just from going forward, think about some of the patients you're making and just, I understand some calls can be a little bit more than others as far as information, but again, this is in the long run to protect you. It's also to protect the department, make sure we're treating the patients like we should. Coming in here, the protocols did we use? What was our clinical impressions? Okay, initially primary, as we're pulling up on scene, I see my patient. He's walking away from me saying, I'm okay, don't touch me. No complaints or injury notice. Secondary, maybe a cardiac arrhythmia, dysrhythmia. If we do see, and this was the question brought up to me from another QA/QI member. I originally said, hey, my secondary impression may be a possible electronic malfunction. But we don't know that, right? So I'm looking at the side of, well, I've been there before where the defibrillator batteries were going bad and there was a recall on them. We were making patients that were getting shocked with them. They're coming at it, well, how do we know it wasn't a cardiac arrhythmia and it was working and it put them back into a normal rhythm? That's true. So again, secondary impression, what do you think? Just back it up. Presence of cardiac pacemaker, no complaints with the supporting signs and symptoms, no complaints or injuries noted. That was my primary. He's not saying he's hurting, so whatever, he's not hurting. An estimation of patient complaint time, and you'll see why this is kind of important when we get into it. Okay. Factors affecting care, uncooperative, no alcohol reported, obviously not pregnant, patient was not transported. So my narrative, very brief and to the point, but I made sure that correlated to what I put within my flow chart and what I put within my vitals and assessment, right? So arrived to find the patient standing in the street as he was approached. Again, we can read this. I'm not going to read this verbatim. You can see it here on screen. If you want to pause it and read it, that's fine. If you just don't even care what I wrote for my narrative, that's fine. Okay, I wrote my narrative, did what I needed to do, come into the forms, make sure it doesn't, and nothing applies to what we did. If we did do some kind of stroke scale, document in here. If we did a stroke scale and he's good, then that's fine, he's good. Billing, we're not going to worry about signatures. Signatures come in, we have a refusal in this case. Obviously, we dotted the I's on this, right? We checked all the boxes, we dotted the I's, we crossed our T's. We come in here and we go ahead and get the refusal done on this patient. Down. Done. I signed it. Okay. Let's see, a correction I need to make. Patient stated he would see his PCR, his primary care PCP, primary care physician. Signature of the patient. Maybe he didn't want to sign it with anything. He just put a line there or an X. That's fine. Maybe we had the officer that was there with us, let him witness it. You know, the guy was not being cooperative. That's fine. We're not going to kidnap him, whatever. So with that being said, in my narrative, let's go back real quick talking about when we refuse a patient, we explain to them that, hey, they may be having something going on that we cannot see. It's our best recommendation that they get seen by at a hospital. Maybe some labs can be drawn, something a little bit more invasive, a little bit more thorough can be done. They still don't want to go. That's cool. That's fine. If we're there with the EMS and we hand them off to the EMS, that's their problem. If we're there without EMS, that's now our problem. Let's get the refusal done. That's fine. Let's check those boxes. But what Dr. Patrick would like to see us start doing, and I'm going to go down our narrative. Right here. If this is in this situation, we went ahead and got that refusal, and I would consider this a difficult refusal, right? He probably needs to get checked out. It's either something going on cardio-wise, or the cardiac issue is leading into the defibrillator working, or maybe the defibrillator is just going off because it's not working correctly. Either way. I put MCHD was advised a refusal was being obtained and the patient was explained the dangers of not having his defib checked out. And there was no reason at the time we could physically see it going off because we did the 12 lead. We didn't see any reasons for it, and that there could be a problem with the device. The patient signed the refusal as required and was witnessed by MCSO. Tells us exactly what we needed to do. Why I wrote that MCHD was advised, because we can do difficult refusals. If we're at a patient and they animally don't want us to do anything with them, they're not going to go. Doesn't matter. Active family members talking to them, they're just not going to go. That's fine. We're not going to force them to go. But I'd much rather us get off scene once we get our baseline vitals done. So we get the initial vitals and a secondary set. We go through our whole refusal process. We dot our I's, cross our T's. We explain to the patient regarding their condition that, hey, this needs to get checked out. If you don't go, bad things can happen. We'd rather you go now since you're awake and conscious. Family cares for you, wants you to go, whatever. But we refuse the patient, but inform them of what we find with them and be specific to what we see. If they don't want to go, again, they don't want to go. But we can get a hold of the district supervisors. They can get a hold of us. They can, over the phone, we can do a different refusal just like MCHD does now when we're on scene with them. So that is something that we are able to do. So just FYI, some of y'all would rather just, oh, if it's going to be that hard, I don't want to handle that. I'd rather let EMS do it. That's fine. But we have the tools in our toolbox to take care of that problem. We can do that. Okay. All right. Call's done. We've gone through the vitals and everything here. We're going to go up. We're going to close this out and see what we got to do. Oh, okay. Yeah, now you need to fill out PPE. So we're going to come here. Okay. So now he was a other caregiver at scene. PPE. He did gloves. No injury. Okay, cool. Now let's go. Let's finish it off. Okay, good. It's done. Everything is validated. We have no nothing we have to go back and no validation issues we need to address. So we're going to lock it. Okay, so this is where we're going to get the review system. Who's reviewing it? What QA, QI members are reviewing it? What we rated it at? What's the clinical coordinate? Right. Again, mark on your call what type of call it was and make sure it's correct because we will mark and categorize it here. Gives us a really quick brief overview of the incident. Clinically, what did we find? So we can look on here really quick and just see, hey, we did a refusals and no transport. So I would come up here, mark this as a patient refusal. And I continue reviewing your call. So now we're going to pull up the pop-outs PCR. So when we pop this out and we take a look at the PCR, we're going to see all the information that you provide. So really quick, if we can get the information as thorough as I did, there's still going to be some spots that we don't get. That's okay. That's fine. But your primary and at least secondary would like to see filled. That would be two of the things regarding the impressions that we all can see that. Let's fill that out the best we can. Signs and symptoms, any additional, what was the mechanism? Again, this wasn't all, no medications, anything that we list in there and we document will show up on our list here. Vital signs, stamp on the vital signs, give us all the information that we need to. 4 leads, 12 leads. Again, any notes regarding those. So when it says other on there or notes, you can fill that out and it'll give us a little bit more information. That's fine. In this case, I was the lead. I did everything. Lieutenant Jazz stood there and maybe he inputted everything into the MDC for me. Mental status. Again, this is what we see when you guys check this stuff out. And right here is your assessments. So anything we document, this is why we want you to document what you can find as best as you can and as thorough as you can. Any notes or comments, it's all right here. Visual assessments. I didn't do a physical assessments of his abdomen, but he was moving around. He didn't complain of anything, so visually I didn't see anything wrong. If he was bent over holding his abdomen going, well, they're cramping up really bad. I could say on here, oh look, he was guarding it, some pain. I didn't see anything. He wasn't complaining of it, so I marked it. Then our narrative, okay, again, it correlates, and it should correlate with what happened up in the assessments and what we find if you're putting stuff. Don't so much care about the vitals. We can look up here and see what the vitals are. We just want to know, hey, vitals were taken, patient was assessed. And if there wasn't the reason for it not being done. But again, if it's a refusal, we should be getting all that information. We should be dotting our I's, crossing our T's, and getting that done. Destination status, if we have something that's fine. In this case, it wasn't a transport. So what times timestamps that we put everything in wasn't transferred, so that was either. So anyways, this is what we see. And a lot of you that I've talked to one-on-one about some of your incidences, and we pull these up, you don't realize that this is what we see. So some of you, when we do pull these up, there's a lot of missing information. Now, yes, the report was complete as far as doing that little checkbox in the validations, but however, it's not complete because we will see a lot of blanks in this, and this is why we ask those questions. Hey, what was the issue? What was going on? So again, all this stuff signed by the patient here, witnessed by the deputy, get what we can. Get these to be as thorough as possible. So with that, some of the main takeaways with this is fill these out the best you can. And remember that anytime we do this patient care, you get a report back, or you get a PCR or EHR, whatever you want to call it, get it back from QA/QI member. We're not doing it to be accusatory. We're not saying, hey, this sucks, you need to redo it. But we're trying to remind you there's some specifics in here that we want you guys to get a little bit better at for some of you. Some of you do a great job. And I understand sometimes that we don't get all the information, and that's fine. And that's okay doing that. Get what you can, and let's go ahead and fill it. And again, if you can't get it, document. Again, this was a medical call, non-trauma call, so it's going to be really easy. The only thing that doesn't translate on here very well is if you do a trauma assessment and you use the anatomical model and label where there's injuries on that patient. All that's going to do on that trauma is it's actually going to place it in here, showing that, hey, you actually assessed it and you touched it. So on a medical call, if you make a notice of somebody with a weeping leg wounds and you want to go that anatomical model and click it there, that's fine. You can do that. It's fine. That being said as well, anytime we're there with MCHD or down south, ESD 11, and we are helping them with a call, if we do any skills that are advanced skills, that doesn't negate our 321 report. Because yes, I understand we're assistant EMS, but you were providing that skill. So don't forget that anytime you touch the patient, anytime you do a D-stick, stuff like that, that's going to equate to a really quick 321 on CPR would be the biggest one, right? We do chest compressions, we assist with the airway. That's not a 311. Yes, I understand we assisted EMS, but we provide an intervention. We some specific skill and don't let that be a deterrent to helping out EMS. Okay. All right. Any other questions? Feel free to reach out to Lieutenant Jaskowiak or myself, and we'll try and answer them the best we can. If you want more of a information or some more questions, you want more specifics regarding something, we will be more than happy to help you out with it. We'll actually pull a couple of your reports out if you want to. If you got questions about, well, what do I do in this case? Call us. I get phone calls outside of work from different shifts. Hey, we're on the scene of this. How do we handle this? What would you do? I would recommend reaching out to your QA/QI for yourself first. And then if you have to, call another QA/QI rep. We'll get the answer done. We'll look it up and we'll get you a solution to your problem or problems, and we'll help you out. And if you got any more recommendations regarding this, that would be great. Go ahead and let us know. We want to make this as easy as possible and something that everybody, it's not such a drab task to get these back from your QA/QI rep and you go, oh great, they're getting on me again, here's 4 reports. We're just wanting you to be aware of some things that we're seeing, and that maybe it's something that's easily correctable, or maybe it's something you were told otherwise. Let us know about it, because we would like to help you out and like these reports to be very thorough. It's not that they're bad at all, and even Dr. Patrick is very impressed with the way we do our reports. He's very, very impressed. He goes for a first responder organization in our meetings. We're way ahead of a curve that he has seen in the past that he's had to deal with. So, all right, guys. Well, that concludes today's little information session regarding EHRs. Again, feel free to reach out via email, text, or call us. All right. Thanks, guys. Have a good day.